So welcome to our webinar to the essential role of caregivers in improving transitions and addressing alternate level of care, or ALC. My name is Bianca Feidelberg, and I'm a project lead here at the Ontario Caregiver Organization. And I'm joined here by my colleague, Lisa Salapatic, and our guest panelists, who I will have the pleasure of introducing shortly. We are so pleased to have you all join from across the province. Looks like we have a great turnout, lots of folks joining. And just to let you know that your video has been turned off and your microphone has been muted, but we really encourage you to introduce yourself through the chat about who you are and which OHT you're with and your role. And let us know your questions, insights, feedback throughout the webinar in the chat box. Before we get started and get to our content, I would just like to acknowledge the land from which I am speaking to you today. I know we're gathering on a virtual platform, but I am speaking to you from the traditional territories of many nations, including the Huron-Wendat, the Anishinaabe, the Chippewa, the Haudenosaunee, and most recently the Mississaugas of the Credit River First Nation. The area is covered by Treaty 13 with the Mississaugas of the Credit, and also known as the Toronto Purchase. And today this gathering place is home to many Indigenous people. And as OCO members, we're learning about the lands from which we work and exploring how we can be meaningful allies and how we can support the recommendations from the Truth and Reconciliation Commission. And we do this to reaffirm our commitment and our responsibility in improving relationships between nations and to improving our understanding of local Indigenous people and their cultures. And I'm so grateful. This is a park near my house, and I have the opportunity. I'm very thankful that I have the opportunity to visit this park regularly. It brings me a lot of peace and joy, and I feel very grateful to live and to work and to learn on this land. So I invite you to take a moment to reflect on the land where you are, and if you're not familiar with that, we will put a link to nativeland.ca in the chat box so that you can explore this further. Okay, so before we get started, for those of you who are not familiar with us, OCO is a not-for-profit funded by the Ministry of Health. And we exist to improve the lives of the Ontario caregivers, regardless of age, diagnosis, of the care recipient, or where they live. And at the center of the work are caregivers. So we offer programs and services to caregivers from across Ontario, including our 24/7 helpline for caregivers, to direct them to the supports and services they need for themselves and their care recipient. Our work includes gathering insights from caregivers and engaging caregivers in program development and design. And I have the good fortune of being able to work with caregivers and system partners like yourselves, OHTs, to recognize, support, and include caregivers at the point of care in healthcare and community settings. Just want to tell you a little bit about how we work with Ontario Health Teams. We work with Ontario Health Teams in these four different ways. The first is large-scale webinars such as this one, learning opportunities. We also offer tailored learning sessions for your OHT focused on the essential role of caregiver as partners in care and the importance of connecting caregivers to support for their own well-being. And as you build your plans, please reach out to us here at OCO. We are keen to collaborate with Ontario Health Teams to develop solutions of how to include and support caregivers in your setting and to improve care pathways. We also have a number of tools and resources available to providers such as Caregiver ID, which some Ontario Health Teams have launched and implemented across their region. And we offer a continuum of programs and services to caregivers, as I mentioned earlier, that are free of charge to support them in their role. And all of this work is done across these three pillars or buckets of work, as we like to call them. The first is including caregivers as part of the care team, as part of the patient care team. And then the second is really connecting caregivers to support for their own well-being. Our third pillar, which is really the underpinning of all this work, is how you're engaging caregivers in your design and planning of your OHT. Next slide, please. That's great. So I am so pleased to introduce our panelists for today's session. And I know we're all so looking forward to hearing from Ida McLaughlin, who's a former caregiver and chair of the Alternate Level of Care Patient and Caregiver Advisory Council, Dana Corsi, Chair for the Ontario ALC Leading Practices Working Group, and Dr. Carrie Kuleski, Research Chair in Patient and Family-Centered Care, Institute for Better Health. So welcome, Ida, Dana, and Carrie. And as I mentioned earlier, I'm joined by my colleague, Lisa Salapatek here from OCO, and I am Bianca Feidelberg. Before I pass it over to hear from Ida, Dana, and Carrie, I wanted to take some time to set a little bit of context. We know that improved transitions and reduced ALC stays are key priorities for OHTs. So as you plan your redesign of a more integrated care model among your many other priorities, we know that from our conversations with Ontario health teams, you're approaching ALC in a few different ways. So some of you are focused on work in the community as a strategy to avoid hospital admission, and others are focused on proactive initiatives within the hospital to reduce transitions to ALC. So in today's session, we will focus on understanding why caregivers are so critical to improve transitions and reduce ALC, and how it's so important to your work as an Ontario health team. We'll hear from Ida, Dana, and Carrie about the insights from caregivers and how the ALC Leading Practices is a tool to guide you in your work to include caregivers. And finally, we hope you leave with some key actions, tangible things you can integrate into your discussions, planning strategies for OHTs. And I just want to let folks know that the session materials, including the recording, slide deck, and a session summary will be shared with everyone who registered shortly after the session. Okay, we are going to launch a poll. So we just want to get a sense from you about how important you think caregivers are in playing a role in improved transitions and reducing ALC stays. So let's see how we do here. I'm just going to give folks a minute. Lots of people thinking that they're incredibly important. You folks are speedy. You're getting this done really quickly. We're almost there. We see some comments in the chat box. Yes, very important. Okay, I am going to end the poll. We're at about 84% who have completed, and share the results. So as you can see, there are many of you think that caregivers are essential for successful transitions, and we certainly agree. And we wanted to spend our time today hopefully sharing some ways that you can ensure that you're including caregivers. Next slide, please. Thank you. So as you consider your work as an Ontario health team and plans for redesign, it's critical, as you've all indicated, to consider how important caregivers are to our healthcare system. So in our meetings with some Ontario health teams, we've learned that for some of you, caregiver support and inclusion has been built into your plans, or caregivers have even been identified as your priority population. And for other OHTs, perhaps the inclusion and support of caregivers at point of care has not been considered as much in your redesign. As you build and meet your deliverables, it's important to note there are 4 million caregivers across Ontario, 4 million, and they are estimated to be providing 75% of the care. So when we like to think about this work as when patients, caregivers, healthcare providers are all working together, we are partners in care and can really successfully improve the key components of the quadruple aim. So, you know, all that work towards improved patient caregiver experience, better patient population health outcomes, better provider experience, and improved system efficiencies. If we're working together, we're better positioned to make that happen. And in particular, if caregivers are essential to improving how patients transition from one sector to another, and key members of a team that can help reduce or avoid ALC stays. Next slide, please. We have learned a lot during the pandemic. It's taught us very much about what happens when caregivers are not included as essential care partners, and there can be a real risk and harm to patients and a risk to our healthcare system. So as your OHT continues to work hard to improve care by attaining quadruple aim and simultaneously meeting the objectives identified in your collaborative quality improvement plans, such as reduced ALC days, caregivers are essential to that work. So we've learned a lot about how caregivers provide valuable support to patients and provide essential information that can impact care. When they're left out of the care team, it can impact patient well-being, creating a missed opportunity for perhaps patient history, increased risk of depression for a patient, or greater risk to culturally safe care, and can potentially cause transition breakdown. And we've heard from caregivers over and over again, when they're excluded, they can't really fulfill their role, and there's a risk to the person they're caring for. So furthermore, this can impact our already strained system. You folks know you're in the system, you're working in the system, you recognize how strained our healthcare system and folks are. When caregivers aren't included, it can really result in a breakdown in care plans, caregivers arriving at the hospital with patients more frequently, a repeat use of the emergency room, and greater risk of ALC designation, and ultimately a higher system cost. So as you strive to achieve your CEQIP deliverables and reduced ALC, caregivers are essential partners in this work. Next slide, please. When we first started to look at the ALC leading practices here at OCO, we were so struck by how much caregivers are built into the leading practices. And I mean, certainly by what we've been talking about here thus far, it makes perfect sense that caregiver inclusion is woven throughout. Caregivers know the patient. Caregivers really, really know the patient and can shed light on patient needs, pathways that will best support their care. Caregivers are key to successful transitions, and without caregivers, there's a risk of transitions breaking down. Caregiver burnout is also one of the risk factors for ALC. If as a system we can better support caregivers, so that's sort of connecting them to the supports and services that they need for their own well-being, we can avoid burnout and help reduce the risk of ALC. And when caregivers are supported for their own well-being and included as value members, they are better positioned to continue in their role. Next slide, please. We know that you're also, as OHTs, tackling some really difficult healthcare transitions in a variety of ways. And we talked about how some of you are focused on working out in the community as a strategy to avoid hospital admission and ALC, while others are focused on proactive initiatives within the hospital. As you redesign your pathways and access to improve care, consider how the inclusion and support of caregiver could really impact a patient's trajectory, both into the hospital, out of the hospital, and across services out in the community. Without the support and inclusion of caregivers, our system's high rate of ALC stays are at risk. Okay, we're going to launch one more poll before we pass it on to our panel. Okay, so this one's just to help us understand how much you know about the ALC leading practices. So go ahead, folks, if you can start putting in your answers there. Some familiarity I see. Great participation here in these polls. Thank you. It's really helpful to see how familiar people are. Okay, I'm going to end the poll here and share the results. So as you can see, we've got, 40%, 47% have not quite haven't seen them, aren't familiar. And then sort of the other half have some familiarity, and a small percentage of your OHTs are using them as you strategize around ALC. So I'm going to stop sharing. I am so pleased now. I mean, it's really helpful to see where people are at with the ALC leading practices. I'm really pleased now to turn this presentation over to Ida McLaughlin, Dana Corsi, and Dr. Carrie Koleski. And it's been an absolute pleasure to be working with them to co-develop this webinar. We're so pleased to have an opportunity to hear from them and share their expertise about ALC. The ALC leading practices, and the essential role of caregivers. So I'm going to pass it over to you, Ida, Dana, and Carrie, and ask you to hop on, and we look forward to hearing your discussion.
Thank you so much, Bianca. And I think, there we go. I just wanted to quickly say hello to everyone and how exciting it is to be here today to talk about alternate level of care and the role of family caregivers with Dana and with Ida. And the relationship I have with Dana and Ida is really critical because Ida, as a former family caregiver, has a lot of insight on, through her lived experience and through her experience of caring for her great aunt, who was ALC a number of times while Ida was caring for her. And Dana, as a health system leader, really understanding what it's like from an organizational standpoint. And the perspective that I bring as one of a researcher who, I listen to people's stories and experiences, and I try to make sense of what's working well and what's not working well. But I feel it's really important to have insights from people with lived experience, people that are leading in the system like Dana, and also researchers to try to pull different tools together to understand a health system issue like alternate level of care. And so what we bring to you today is perspectives from each of our experiences, but also pulling from our broader experiences with other stakeholders and partners. But before I go too far, I'm not going to go into the discussion just yet because we thought we should review the leading practices first so people could see how the roles of caregivers have been integrated into the leading practices, because the initial version of the leading practices, which came out some time ago, actually didn't really include anything about caregivers. It didn't include anything about partnering with families and caregivers, and it didn't consider the role that families play in the care transition of people. So Elaine Burr was the core author, along with many partners, on the first set of leading practices. I remember seeing her. I was sitting in the hallway at Bridgepoint Hospital, and she came up to me and she said, "You know what, Carrie?" She goes, "So you're one of the people doing research on care experiences of people who have have an alternate level of care experience." And I said, "Yes." And she said, "You know what? We need to collaborate," because she goes, "I fully admit the first set of leading practices didn't consider in a deep way the roles and the experiences of families." And so we were able to build in that work, which we'll speak to throughout this discussion. But first, I'm going to hand it over to Dana to talk a bit more about the leading practices, pull some examples, and talk a bit about how caregivers have been integrated. So over to you, Dana.
Thanks so much, Carrie, and just another shout out to Elaine Burr, because she is the 6 degrees of separation for all of us. That's how I met you, and really in her role as patient flow lead within the Northeast, that's how I discovered my passion for alternate level of care, coming from a clinical background, working in a hospital acute care rehab setting for most of my clinical career. It was that partnership with Elaine where, again, realizing some opportunities to really build upon the existing leading practices, that I have a chance to be here today to speak to the leading practices and speak to the importance of the caregiver as an embedded piece within this new version. So thank you so much. You can go to the next slide, Allison. Thank you. So to Carrie's point, and it's really great to hear from the poll that there are folks on this webinar who don't know very much about the ALC leading practices, or maybe have taken a peek, and it's good to just provide some context and some grounding before we jump into our conversation following the slides. And as Carrie mentioned, the original 2017 ALC leading practices that you may be more familiar with really were built in order to provide a standardized set of ALC practices across the province that hospitals could use to support, and as Elaine would say and own today, getting bums out of beds. It's not the terminology we aspire to use. She owns that, but it was the start of the conversation, and really focused on administrative and operational processes. So estimated date of discharge, escalation processes, those sorts of things. And as Carrie referenced, the lessons that were learned through research, through quality improvement initiatives, through trial and error with those original leading practices were really two keyfold ones. The first one, of course, and why we're here today, and we're going to talk more about this, is the fact that there was a huge opportunity to include patient and caregiver perspective, including enhanced engagement and communication. And the other piece that has been integrated as well is the need for an enhanced focus on senior-friendly care and rehabilitative care principles. So really focusing on the need and recognizing the need to integrate care processes across the continuum with this version. And so what we have, Carrie and myself and others who I know are on the webinar, we had the opportunity to come together as a provincial working group. And when we looked at the original leading practices, one of the first things we wanted to do was really be able to take a population approach to those leading practices. Who is most at risk for becoming ALC, and how do we start to orient the practices around that? So just as a little bit of context, again, we discovered and validated that across Ontario, 80% of individuals designated ALC are over the age of 65. The largest cohort, so 64%, are over the age of 75. Probably not surprising. But also, it doesn't mean there aren't other populations. There are many other populations that this designation applies to, but we wanted to focus on the largest cohort, so hence the older adult population. The other piece that we looked into the research about was common characteristics of folks designated ALC or most at risk. And unsurprisingly, it was an admitting diagnosis that included general medical illness, so as an example, infections, falls, and dementia. The presence of functional or cognitive impairments and multiple comorbidities, and the experience of adverse events during admission, so functional decline, delirium, falls, social isolation, and of course, caregiver stress, as Bianca mentioned, was one of the key common characteristics of individuals at risk for ALC designation. So our goal with these leading practices was really to address meeting the needs of this population that was most at risk. You're good to go. And as mentioned, we put together this provincial working group, which brought together a range of experts in the different aspects of alternate level of care that really needed to be integrated within this revised version of the leading practices. And you can see the different references on your screen in terms of the Regional Geriatric Program of Toronto, Provincial Geriatrics Leadership Ontario, Ontario Health, Ontario Hospital Association, of course, Carrie, and the work that she's done with IDA and the Council, Rehabilitative Care Alliance. And what we did was we built this new version of the leading practices to incorporate best practices and flow processes from the original 2017 version, and then added an enhanced older adult and care partner involvement leading practices, as well as those critical components related to senior-friendly care and enhanced rehabilitative care. This just captures the evidence that is embedded along the and into the ALC leading practices. So again, I'll just highlight the Better Care Journey website that speaks to a lot of the tools and information that was provided by the council and their experience with alternate level of care. And then just to highlight for you as OHTs and the work that you're doing, that what's beautiful about the leading practices is that they integrate existing provincial clinical guidelines into one document. It takes senior-friendly care, comprehensive geriatric assessment, clinical quality standards, and many other documents, and integrate them into one approach to care that proactively mitigates and addresses alternate level of care. And then critically, all of these leading practices are aligned to Accreditation Canada standards and required organizational practices. So really, taking a lot of things that tend to run parallel in our system and putting them together into one package. And finally, just for your reference point, the other thing that, and we'll talk a lot about this when we get into our conversation, but what these leading practices do is they focus on an individual and their caregiver's patient trajectory, or the care trajectory. So thinking about wherever an older adult and their care partner enter into the system, what are those leading practices that can support mitigation of ALC? So in the community, thinking about proactive identification and long-term management, how do we sustain people where they want to be in the community? How do we avoid unnecessary admission by continuing those ALC leading practices through into the emergency department. And then similarly, as people are admitted into hospital, what are those leading practices that avoid hospital harm and enhance well-being? With the foundation of all of it being, how do we, if we know that 80% of ALC designations are for older adults, how do we look at flipping care and really making the foundation senior-friendly care, which in and of itself is based on patient and caregiver engagement and involvement. So with that, I hope that's a good synopsis or quick intro. Hopefully it was a quick intro to the ALC leading practices, and excited to chat more about that with Ida and Carrie.
Great, thank you, Dana. And as you were talking, I was also looking at the chat, and Chris had an excellent suggestion about a caregiver well-being index and the importance of assessing the needs of a caregiver. So just wanted to highlight the leading practices are very much a live document. We have the latest version, but as we talk today and discuss and share different resources, there's an opportunity to continue to build the inventory of resources that we have and to share it more broadly. So please continue to provide additional insights and resources as you have them and would like to share them. Before we flip it over to Ida to talk more about her personal experience as a caregiver, Dana, I just wanted to actually kind of back up a little bit. I'm assuming everyone knows what alternate level of care is, but I don't want to make that assumption. We probably should have defined it a little earlier on. But I'm wondering, can you put it in context? So for example, when we talk about a care transition, what do you mean? Where does it start? Where does it end? And how does ALC fit into that?
Yeah,
context.
Great question, Carrie. And cut me off if I go too long, because I tend to run on here. But I think, so first I'll start with the care transition piece. You know, again, coming from a clinical background in a hospital, what I found, and now as I work in this sphere, I find that there is an automatic jump to a care transition being moving out of somewhere. So discharge from hospital, it's the end of the journey. And I think what is essential and how we wrote these practices, and when we think about a patient and caregiver journey, is care transitions start right from the point of entry into whatever part of the healthcare system someone is working within, or wherever that patient and caregiver are accessing care. The patient and caregiver are the constant. How they interact with different folks within the community, within the ED, within the acute care, those are each in and of themselves transitions. The transition between different providers, the transition between different services. And so it really starts then. It may sound cliche, but it is absolutely essential that we start to think about how those transitions and the information that is required to support any of those transitions along the continuum really begin at that entry point. And I will answer the second part of your question by saying, I think ALC, or alternate level of care, is exactly the same. Alternate level of care, we talk a lot about it as a system. It's an outcome. It's at the end. There are so many things, i.e. the leading practices, conversations with caregivers, that need to happen prior to that ALC designation, or in order to inform the most appropriate ALC designation or outcome. And I think it's that upfront work and conversation and focus and knowing the person that is the key to all of this.
Thank you for that, Dana. And I think if we look at sort of the standard, CHI high definition, it's about, a delayed hospital transition. So a person's basically in the wrong place of the system and they're waiting to move, but there's tons of opportunity to avoid it by doing things proactively, engaging with patients and families proactively to understand their context. And speaking of caregivers, I'm so grateful that we have Ida here today. I've had a chance to partner with Ida on many ALC projects for many years, and I learned a lot about her great aunt, Sarah, and Ida's experience in caring for Aunt Sarah for many, many years and many, many transitions. And so Ida, my question for you is, when you think back to the different experiences you've had with your great aunt, particularly around care transitions and sort of those alternate level of care type experiences, can you think and provide some examples of what worked well and maybe what didn't work so well? What kind of stands out in your mind when you think back on your experience?
Thanks, Carrie. Yes, I've had the pleasure of working with Carrie, so she's heard many of these stories, but I will certainly choose a couple of things to share with you. So firstly, I'd like to say that, you know, ALC is never easy, neither for the patient nor the caregivers and family. So although I may concentrate a little bit on the things that didn't work, I do want to say that there are some positives, one of which is that the nursing staff, the doctors and so forth do their very best during ALC, but their hands are tied, as you all know, because care is supposed to stop. And so they do their very best. And I want to make sure that I highlight that, that there are caring individuals out there that want to make sure the patients are doing well. Saying that, my experience hasn't been the greatest through ALC. Firstly, it's essential, and from my perspective and from those of the patients and caregivers that I've talked to include them right from the start. The care plan, being part of the care team is essential. And I'll just give you one example of something that had happened with my aunt where I was excluded from the conversation. And that was around her medication when she was in hospital. I had indicated at one stage that her geriatrician had made it clear that it's very important for my aunt not to have been on any kind of sedation at all or something to help her sleep. Because she had trouble sleeping, she had asked a nurse for something to help her sleep, and they gave her some medication to do that. And just as we had expected, she became confused. She was not physically well. And so she fell out of bed, fell onto her face, was lying on the floor for several hours, had many injuries because she was wearing glasses. And so she was injured pretty badly. And so not only was she physically injured, but also her emotional well-being was jarred. So she felt less confident. She was scared. And because she had been on the floor for several hours, her stay at hospital was extended. And so there we have a bed that could have been used for someone else had people paid attention to what was essential in her care. And that's where caregivers are so important. The other experience that I had is during ALC stays. My aunt was placed somewhere in rehab, and it was so far away that it took me 3 hours per day to get there. But because she was ALC, I felt it was essential for me to be there to help her and prevent any kind of decline. So I needed to be there to help her get dressed, get out of bed, those kinds of things. So that's another issue that caregivers need to consider is, you know, how do they manage this care when care is stopped? I hope that answers your question.
Oh, thank you, Ida. There's so many important nuggets in what you said that I just want to quickly highlight. The first thing about the medication between what the geriatrician was recommending and then what the hospital administered really speaks to the importance of cross-sectoral, cross-provider communication. Also, it speaks to the importance of communication with the family who has that knowledge, the context, that nuance that is really important, you know, to be considered in the care plan. So having those ongoing conversations with families are critical in order to mitigate harm, which is, you know, what happened unfortunately in your aunt's situation. So being, you know, family caregivers are not only providing a lot of care and support, the knowledge they bring and the insight to help paint a fuller picture of what needs to happen when the person is in hospital or elsewhere. Another thing you talked about with the geographic challenges, I hear that a lot from other caregivers too. And I think, you know, I wasn't going to say it, but Bill 7 has huge implications for that in terms of the distance that family members might have to go, you know, in order to provide supports. And will have important implications for quality of care that will have to be considered. So I think it's something we're going to be hearing more about. And also we'll have to consider how will we support families and caregivers to be connected if there is that geographic divide between them to continue to support them in the hospital. But I'm going to flip it back over to Dana now. And, you know, sometimes when we talk about alternate level of care and care transitions, we think it's like a hospital thing, like it's the hospital's fault, it's the hospital's problem. That's obviously not the case. This is a system-wide challenge, and you've highlighted that in the leading practices. But can you speak about, like, what do we need to do though when someone is in the hospital? Like, what are some recommendations related to, you know, with working with caregivers and partnering with them versus outside the hospital? Are there some differences in what we can do? And maybe you can relate that back to the leading practices a little bit.
Sure. Thanks, Carrie. Well, I think I'm just going to build on Ida's examples, because those examples really flag the essential pieces that apply to both the community and the hospital. Yes, how we deliver or achieve each piece is going to look different based on whether it's in the community or in the hospital. But there are two key things from what, well, there's many key things from what you said, Ida, but two key things that I took from it that are really part of the ALC leading practices, specifically so that those things can be addressed as individuals enter the system, is number one, that, and you said it, we need to know the patient, the person, and their story. And, you know, yes, we get that story from them, but a lot of times we need to get the collateral story and the collateral information and confirm or get more details from the caregiver. Without that story, we can't develop a treatment plan. We can't understand what a person's care needs are, what the right goals of care are according to what matters to them. So it's that knowing the person and not assuming that based on what we see coming through the doors. And I think this is a essential, like a really specific one to the hospital environment. When we see someone coming through the doors in a hospital gown, out of context, not in their environment, it's so easy to make assumptions about what their story is. We need to get the story, and we need to leverage our caregivers, care partners to help fill in those blanks that we have in the story to get the big picture. The second one that is essential is, once we have that big picture, and this is the starting point anywhere, is we need to ask ourselves the question, and whether this is a service, a person, whomever, we need to think about it as, has there been a change? Has there been a change in this individual in terms of how they do their everyday things, getting dressed, walking, their roles, their abilities, and really understand what that change is, and that degree of change between who they were before they got sick and what we're seeing in front of us. And in the community, that just looks a little different. And you think about the role of primary care and how important they are to understanding the person over time. They probably know when someone comes in or can see some change right away, but it's making sure that that change is really articulated beyond the things that are obvious and what else is going on underneath. So I hope that answers your question, Carrie. I can kind of go on tangents there. So
thank you. No. I always love listening and talking with you. And so my big takeaway is that, you know, as people come to the hospital, that's not their baseline. This is what, you know, what they look like because they're in hospital, they need hospital care. But there's a whole background story about, you know, things that have changed over time, and understanding and asking the question, what has changed, helps you, you know, get that broader context. I'm going to go flip it back over to Ida, because I just want to enforce or talk a bit about different kinds of engagement. So a lot of the leading practice is more of the frontline engagement with families. Ida and I have worked more at a research partnership level of engagement, where we co-design things together with other patients and caregivers to build things that we think will help families and patients as they transition through the system. So Ida, did you want to reflect on any of the work that we've done together, the sort of the resources that we've developed that you think might be helpful for OHTs to know? And just wanted to flag that these have been embedded within the leading practices. We have some resources that were co-designed with people like Ida and put them in the leading practices, thanks to Dana. So Ida, did you want to speak to any of that?
Sure. Firstly, I saw in the chat there that some people were questioning what sorts of care stops or diminishes. So I just wanted to tell you my experience with ALC. So The first time my aunt was designated ALC, I just noticed that there was a change in her care, and nobody had explained to me why that was happening. They didn't tell me that she was ALC. They didn't even describe to me what ALC was. I had assumed that her care had changed because I actually went to the head of the department and indicated that, you know, there were some difficulties, and I felt that maybe they had taken my comments about her care as a complaint, and in retaliation to that, her care had stopped or declined. And so I felt terribly guilty that here I was putting my aunt at risk. It turns out that she was ALC. So ALC, alternate level care, is where they designate a patient as ready to leave hospital. So in essence, they don't require care any longer, at least not acute care. And so the bare minimum is provided. At that time, my aunt was fairly active prior to being in there, even though she was in her 90s. And so there was, physio had stopped. Nobody had gone in to get her out of bed and dressed. Those kinds of things all stopped, and she was still getting medication and some of the basics, but that was about it. And so my being there every single day was to help ensure that she doesn't decline even further, and her activity level was maintained. So what would have happened, what would have helped me is much more communication with the care team. So again, being part of the care team would have really been helpful, as being part of it right from the very start. But also some sort of communication tool. And that's what we as a council had developed, as Carrie said, through research. We work with other patients, caregivers, and providers. And so this communication tool that we developed, which is embedded in the leading practices, is available for everyone to use. And when you have a moment, I know that we're kind of close on time here, so I'm not going to get into it. But please take a look at this communication tool. It's really valuable, and we feel that it would be helpful for anybody going through what I went through and what other people are going through currently.
Thank you for that, Ida. And getting back to the resources that are included, the communication tool prompts the care team to describe like what ALC means and why care is changing and why there might be a bit of confusion for that period of time. And some key questions really kind of hone in on like, what are you most afraid of? What are your concerns or your key concerns that are directed to patients and caregivers to start to get right at kind of those core goals and maybe challenges that people are worried about, to then build the care plan around that. So the questions themselves kind of force the team to be a bit vulnerable, to kind of open up, you know, and say, okay, like, let's talk about this. This is going to be tricky. We have to figure this out, but what really matters most to you? So it gets at stuff like that. I know we're running out of time, but Dana, I wonder, you know, people participating today might be like, where do I start? Like, what do I do? Is there something they should do first? Or is there like a leading practice they can say, okay, I'm going to pick this one, or is this a whole package that you do together? How do they get started?
Just start anywhere. So the self-assessment that goes along with the leading practices will be shared as well following this conversation. And I think the key is to just understand where your organization is at. What are we currently doing? What we need to embed these things so that they become the standard of care, that this is the minimum standard of how we do things. We involve patients and their caregivers as part of the team. So when there's a section that has 4 leading practices, it's right in the organizational piece, and it goes through, you know, involving the caregiver as part of the team, and 3 other pieces. Doing that self-assessment to start, even doing one of those questions to start would be great, just to understand and to bring it to the forefront in terms of, yeah, we need to pay attention to this, and we need to understand where we're at.
Thank you for that, Dana. And I see we're at time. I had way more questions, and of course we always run out of time when we start chatting, but I wanted to try to put my qualitative hat on and think about some of the core messages and themes that came out even in the chat. I'm going to try to integrate that, but I didn't see all the messages, so I might miss some. I think the first one that really stood out for me is asking families and patients what changed. You know, they're not assuming that when they present, say in the hospital, that that's a reflection of who they are. So trying to understand who's the person, what is their context, what has changed, to get a better understanding of, you know, who they are and what they need, which will then inform, you know, the rest of the journey in that care plan. The second one is really to honor the caregiver perspective as valid, critical knowledge that helps to kind of complete the puzzle, you know, that presents when someone's in, you know, needing care in any setting. And really honoring that knowledge, valuing that knowledge, and inviting families when they're available and willing as part of that circle. Oftentimes what I hear sometimes from hospitals is if there's a crisis, or if the transition goes really badly, then there's a family meeting. But why not just automatically try to have a family meeting to then unpack what's needed and what some of those priorities are? Pulling in a key message from the chat was a family member might not be available, they might not be willing, that for many reasons due to stress, etc. And so, you know, having an advocate available, having someone that could support that patient and navigating the system and helping to navigate the communication and the questions that will need to be asked is critical, because not everyone has access to a family, friend, neighbor, caregiver. And so what is the system's responsibility in providing that support? That's a key question. And, you know, by investing the time upfront will help us help the care team and the system kind of manage across the system of care. So not waiting until, you know, that ALC label has been applied, but thinking upfront, everyone that comes into the system, are there things we could flag proactively to try to, wherever possible, get people to the right place of care, but also just ongoing communication with families through that process when the family is available to be part of that discussion. So I know there's many other key insights, many in the chat too, that we can integrate later, but I'll leave it there. And I believe now I'm passing it over to Lisa. And thank you, Ida and Dana. We have so much more to dig into, but we'll have to save it for another time.
Thank you so much. I just wanted to say a tremendous thank you to Ida, Carrie, and Dana for being our panel today. We'll get in a moment to opening up to some questions for you. I'd like to give, though, a special thanks to Ida for sharing your personal story about your Aunt Sarah. I know that if I had been on video, you would have seen me nodding and shaking my head at times as you spoke, and no one could really have brought this topic to life better than you with a caregiver perspective. So thank you so much. I'm Lisa Salapatic. I'm part of the OCO team, as Bianca had alluded to earlier, and I have the pleasure of just facilitating this last part of our webinar today. And I am, you know, after hearing the panelists, I'm just so excited about the opportunities for OHTs to be really thinking about different ways to truly integrate caregivers as part of the care team when we're thinking about ALC and transitions. Before we open up for questions, I'm going to highlight 7 quick takeaways for OHTs and just point you in the direction to highlight some of the resources that are available to support these action steps. First one, which I think goes without saying, is especially since, you know, we saw from the earlier poll that some of you hadn't known a whole lot about the ALC Leading Practices Guide before heading into this webinar. So we hope that it'll be a useful tool to inform your planning work moving forward. As part of the Leading Practices, there's a self-assessment tool, which might be a really, really great place to start. And Carrie and Ida really underscored the importance of co-design engagement of caregivers in these conversations about ALC solutions and improved transitions. Next slide. The other 4 that I'll just quickly highlight really relate to what can happen at the point of care. One of those is formally identifying the caregiver, and one of the leading practices is to identify and document the designated caregiver or the SDM, substitute decision maker, within 24 hours of admission for an older adult. So that's an example of kind of the actions that can be taken to formally identify caregivers. In our follow-up materials, we'll also provide you with a link to the caregiver ID tool, which can also be a very useful way of identifying caregivers and facilitating their inclusion as partners in care. Also, building processes and training to include caregivers in early proactive assessment, care planning, transition planning. And this is really, what I see as being a lot of at the heart of the leading practices. And there is just are so much good information and very, very specific tips and pieces of guidance on how that can happen. I don't think that anyone could have brought to light better than Ida the importance of transparent communication with patients and caregivers about ALC. And I know that the communication tool that both she and Carrie spoke to, that had been developed as co-designed as part of the group that they were, is a really, really valuable tool with really helpful guiding questions to support those conversations. And then the last point I'll speak to is just we have spoken to a couple of several times throughout this webinar about the connection between caregiver distress or burnout, and that being a risk factor for ALC designation. So that really underscores the importance of thinking about how caregivers can be connected with the supports, the tools, the resources that they need, not just to do their caregiving role, but also to take care of themselves. And we at OCO have worked with a number of OHTs on ways that caregiver supports can be built into access and navigation models. And the OCO also offers a really broad range of caregiver-focused programs and services that are available for caregivers across the province, may be very useful and complementary to the types of supports that you may be offering locally, particularly at the community level within through your community partners within your OHT. So I am going to now move us into a few minutes where we can have a bit of time for questions from the panel. So I'm just going to go quickly into the chat box, and Allison and Bianca, if you've had a chance to already look at the chat box and there's any that you want to bring forward immediately, please jump in. Just scanning through. There was a question about language and documentation around behavior on presentation to the ED can change the entire course of the stay and increase ALC days and increase also transitions within the organization. Such a good point. Thank you, Mary. I don't see anything about advanced care planning in the communication tool. That would be something important to address. So maybe Carrie or Dana, could you speak to whether or not that came up within the course of your conversations in developing the leading practices?
Lisa, was it relevant to the communication tool or the leading practices piece?
I think the question came up related to the communication tool, but I think the theme of advanced care planning could apply to either.
I know that within the leading practices, there are some pieces that speak to the need for, or speak to the inclusion of advanced care planning as part of that comprehensive assessment. Off the top of my head, I don't remember which numbers specifically, but I'm happy to, provide those references and for folks.
And as for the communication guide, the questions were more tactical about the actual transition in terms of, what are people concerned about? Some questions that patients and families should ask the care team about what to expect, how care is going to change, what they can expect in terms of the next stage of care. So it was more about kind of tactical and like kind of that immediate care transition experience as opposed to advanced care planning.
I believe we also had a question a bit earlier on about other populations that may still be designated ALC. One example that was given was young disabled persons. And I'm wondering if perhaps, Carrie, you could maybe start off with just any comments you have about the kind of how the leading practices could be applied to other populations.
Yeah, I think it's interesting when I think back to the very first ALC study that I did actually up in the north, looking at the experiences of patients and caregivers. And what really kind of surprised me at first, I had assumed that most of the participants would be older with chronic comorbidities, but we did have a younger gentleman who had a significant accident who was in hospital, and the critical piece was that there was really no appropriate care setting for him. you know, going to long-term care was not really an option. Going home wasn't an option. It became clear that there was a significant gap for younger people with significant medical complexities, and it could be, you know, related to the particular context and community that he was part of. But however, a lot of the things that are part of the leading practices guide related to understanding the person, understanding their context, their preferences, what matters most to them, where, you know, where they want to go next is very applicable to any population. But there are some unique features around that particular context, particularly when it's unexpected. And in this case, it was a significant accident, and the family was coming to terms with what happened. And there's a lot of shock that had to be acknowledged and dealt with and talked about before, you know, care planning could actually happen. But there's definitely a significant difference with that population.
Thank you, Carrie. We had quite a bit of dialogue, a little bit throughout the webinar, and some chats in the chat box about what services in hospitals stop when a patient is designated ALC. And Ida spoke of caregivers having to pick up on some very basic supports. Maybe I'll throw that one first to Dana, if that makes sense.
Sure. I think and someone addressed it in the chat in the sense that the same approach to care is provided in an ideally resourced setting in acute care. With the resources that are available, what happens is the attention shifts to folks who have more of an acuity medically, and so the focus and those resources get prioritized to those patients, and that's my understanding. And so it's not that the goal isn't to get people up, dressed, out of bed, but there's just a shift in where those resources go. And so what often happens is that folks may not receive that care, as in Ida's case. So I don't think I think it's just an opportunity, as we've done in the leading practices, to flag that this is essential care, regardless of designation, that acute care, as we know it today in 2022, is combining the medical need with the personal functional goals, and addressing them both. And how do we do that within the setting of acute care?
And if I could just add to what
Thanks,
Dana
Ida.
said, that what people need to recognize is that when care stops or is less than they're accustomed to, that they do decline. And so that delays them going into the place, their next place, whether it be long-term care, home, and so forth. So it's kind of cyclical. So we have to just pay attention to the fact that, yes, maybe they don't need as much care as if they were in acute state, but care is still required. And we as caregivers know that more than anyone. Thank you.
And Ida, I'm so glad that you jumped in, because that will leave the final word with you in terms of closing off on today's webinar. Thank you so much to everyone for joining. Again, we have our contact information on screen, and we will be sending a follow-up to everyone who registered with the slides, some follow-up messages, and a recording of the webinar. So please, thank you for your active participation today. And we are also eager to connect with any OHTs who would like to further discuss areas of opportunity for caregiver inclusion and support. Thanks to everyone. And thank you to our panelists, for Ida, Carrie, and Dana, and Bianca, for all of your work in pulling together today's webinar. Thanks so much. Bye-bye.